Okay, so we're going to talk about scatter control, and this is Faber once again with the new edition. It's a different chapter than what I have listed, so make sure you pay attention to that. Here's your objectives as usual. Make sure that you can answer these questions. So, scatter radiation. So what is it? It's determinal to the radiographic quality because it adds unwanted exposure or fog to the image without adding any patient information. So it's all negative. So scatter is bad. We want to get rid of it if we can. So radiographic contrast will be decreased because there's going to be a layer of density on the image that's taken away your contrast. So increased scatter radiation either produced within the patient or high energy scatter exiting the patient will affect the exposure to the patient and anyone within close proximity, and that's what we're talking about, the Compton, and that's your occupational dose. So increasing the volume of tissue irradiated results in increased scatter production. So if the patient is thicker, you're going to have more scatter, and it's also dependent on your X-ray beam field size, so we want you to collimate as much as possible. And higher KVP increases the energy of the scatter radiation exiting the patient. So the best ways to control scatter, the number one thing that you can do is collimate. So we call that beam restriction. So beam restriction devices decrease X-ray beam field size and the amount of tissue irradiated, thereby reducing the amount of scatter radiation produced. That is the number one thing you can do is collimate, reduce your beam size just to the anatomical part that you're interested in. You can use radiographic grids. They're used to improve radiographic image quality by absorbing scatter radiation that exits the patient. So it intercepts that radiation and absorbs it so it doesn't hit your image receptor. All right, so with beam restriction, it limits the patient's exposure also, so that's very good. Reduces the amount of scatter radiation produced within the patient. So if you can decrease your beam size to make it smaller so that less radiation is interacting with the patient, that's less dose to the patient and less scatter radiation coming out of the patient. So it's got a lot of positives to it. So beam restricting devices change the size and the shape of the beam. So the primary beam, not the remnant beam, the primary beam. So collimation, increasing collimation means decreasing the field size, and decreasing collimation means increasing the field size. So it's very confusing. In your book, they're going to talk about increasing collimation. So that means it's actually decreasing the size. And if they say decreasing collimation, it means they're making it bigger. Very confusing between the two because a lot of us say you want to decrease your collimation. But in reality, and I even did it just now in your PowerPoint, I said you want to decrease your collimation. Decreasing your collimation means you're making it bigger. So I'll practice on saying that properly, and you need to know that decreasing collimation makes it bigger, increasing your collimation makes it smaller. So less scatter radiation is produced within the patient, and less scatter radiation reaches the image receptor. To maintain exposure to the image receptor, mass must be increased. So the tighter you collimate, so the decreasing collimation, you will have to increase your mass in order to compensate for the absorption of the photons. So there's aperture diaphragms, cones and collimators, and cylinders and collimators. So the aperture diaphragm is a flat piece of lead. It's a diaphragm that has a hole or aperture, and it is placed directly below the X-ray tube. There's like little slots that you can slide it into. There's also cones and cylinders. It's an aperture diaphragm that has an extended end that flares, or they can be long and straight. And then the collimator is located immediately below the tube, and that's your collimator box. It has usually 2 sets of lead shutters that limit the X-ray beam size. So you can see here, this is a cylinder here, so it's just long and straight. And these are really good for any kind of head work, TMJs, sinuses, anything real small. This flared cone here, so you can see it's flared. This is really good for doing skulls, different areas where you need really good detail. And this is what you're used to. This is in your collimator box. You can see your shutters. You have shutters that decrease your field size or increase your field size. All right, so grids. A device that has they have very thin lead strips with radiolucent interspaces. So it's intended to absorb scatter radiation emitted from the patient. So they have lead strips with a radiolucent interspace in between each lead strip. We're going to talk in another class about your grid frequency and your grid ratio, but your grid ratio is the height over, don't even worry about it. I don't even want you to know it at this point. So just know that we look at the grid ratio, and I'm going to show you examples of what the grid ratio is, like 12 to 1, 8 to 1. So I just want you to know that there is a grid ratio, there is grid frequency, there are formulas for it. So I'm not going to make you learn them yet, like you. All right, so grid patterns. There's different grids out on the market. This is a linear grid pattern, so it's long lines, and you can see a cross-hatched grid here. So it's a bunch of squares. So in between each square is the radiolucent material. So here these lines are the lead, and in between is the radiolucent material. And most of the time it's aluminum to absorb some of the low energy. So grid, this is a focused linear grid, so you can see the lines are going lengthwise, or the length of the grid, and you can see that it's angled here. Well, this is straight, so this is this is a parallel grid, a linear parallel grid, so all the lines are going straight up and down, as you can see here. So as you can see with the divergent beam, that it's absorbing your divergent beam because it's only going to allow the photons going straight to hit the image receptor. So you can see we have grid cutoff on the sides, and when we get into your next level physics class, we're going to actually calculate that. So just the photons coming straight are going to make it in between the inner space to hit the image receptor. Now this here is a focus, a linear focus grid. So you can see that the lines are angled and the photons are able to slide right in between each of the lead strips. So this is set distances. So when you have a linear focus grid, you need to know, is it a 40-inch or is it a 72-inch? So your distance matters. Okay, so if you take, this is the convergent line and the convergent point. So this is a linear focus grid, which means that the lines here, each lead strip is angled for the distance of the convergent line. So if this is 40 inches, it knows that the photons are going to come out at the exact angles, and the lead strips are going to be angled to what the photons are going to be coming out. So you can see here, this is the grid. You have your image receptor underneath. This is the 40 inches or 72 or whatever the grid is, and it's coming through exactly at the angle of the lead strips. So the lead strips are going to be more straight in the middle and more angled towards the periphery on both sides. Reciprocating grids. So they're stationary grids. So that's what you take up on a portable, and you put a grid cap, they call it a grid cap, on your 14 by 17 to shoot an abdomen. Sometimes you guys use them for chest x-rays in addition. So you're going to pop that on top of your image receptor, and that is a stationary grid. You're going to see little teeny grid lines on that image. It's just inevitable. It cleans up a lot of the scatter, but you're going to have grid lines, so that's the downfall. If you have a grid that moves just a little bit, so we call them reciprocating grids in the Potter-Bucky diaphragm, it's controlled electronically and it pulsates. It makes a noise, it goes chink, 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 chink inside your table. So when you have a oscillating or reciprocating grid, it blurs out the grid lines. Therefore, you can't see them. Okay, so you have long versus short dimension grids. So you have a short dimension grid right here. So you can see on the short dimension, you have the lines going. This is the long dimension, are the lead lines. So this one you're going to use for a chest x-ray because you're going to come in at an angle so that if you angle this way, you're going to have grid cutoff. So you're going to angle down or up, so caudal or cephalic, and you're not going to have any grid cutoff. So it's perfect for a chest x-ray. This is perfect for a KUB, so, or any kind of long bone, anything like that. So this is a long dimension, so you can lay the patient's head here and the feet down here and shoot the abdomen, and you can angle cephalic or caudal, but you can't angle left or right. All right, grid cutoff, and that's the reason why you can't angle on certain ways. You got to make sure you have the right grid, or else you're going to have grid cutoff. So grid cutoff is the decrease in the number of transmitted photons that reach the image receptor because some misalignment of the grid. So there's different things, and I showed you some of those in the other PowerPoint that is posted. So an upside down focus grid, there's off level grid, off center grid, and off focus grid. So this is an upside down grid, so only the photons going straight, so where the lead strips were straight is going to make the exposure, and then it cuts off on the sides because the lead strips are absorbing all the photons on the periphery. And this is demonstrating an off-center grid. So when you have a focus grid, you have to be centered, or else the divergent beam is going to be off. So you can see it's fine here, but it's cut off over here. And this gives you an idea. So this is an off-level grid that causes grid cutoff. And a lot of the times when you have a focus grid like this, a linear focus grid, and you're shooting a KUB on an ICU patient on an air bed, you're not going to have it totally flat. So you're going to have some grid cutoff where you're going to have some missing data on there. So it's really important that you try to get that grid as flat as possible. A lot of times we'll have them turn the airbed off so that we can get the plate with the grid cap on it as straight as possible. And then here you can see centering to one side of a focus grid can cause grid cutoff. So if you're straight on, you can see that it's coming through at the proper distance and with the angles of the lead strips. But if you're off-centered, the divergent beam is off, so you're going to have some grid cutoff. Okay, the Moiré effect. So I'm just going to tell you what this is. We're going to go into a lot more detail about it as we go into your image receptor class. But it's an artifact demonstrated when a stationary grid is used during computed radiography, and the grid frequency is similar to laser scanning frequency. So when it's scanning the plate, it's finding that the grid lines and the pattern, the roster pattern, is the same, and it gives this weird look to your images, and it's called the Moiré effect. So when are you supposed to use a grid? Any anatomical part 10 centimeters or 4 inches or larger. So 4 inches isn't a lot. So a shoulder, a knee on an average sized person, you should be using a grid. Examinations requiring higher than a 60 kVp. Pretty much everything's shot at a 60 kVp. So higher the ratio grids will increase the scatter absorption, increase the patient exposure. Why are you saying it increases the patient exposure? Because the grid is after the patient, it's in the remnant beam, and if it's absorbing a lot of radiation, a lot of the photons, we have to increase our mass. When we increase our mass, that's directly related to patient dose. So it is an increase in patient exposure when we use a grid, but our image quality is so much better. So it's a trade-off. And you increase the potential for a grid cutoff. Okay, so typical grids that we use linear. We don't use cross-hatched anymore. We use focus grids instead of parallel. And you know, I agree with this, but lately I've been seeing a lot more parallel grids, just parallel. So very interesting. I'm not sure about that. Ask at your hospital what you're using. We use a mid-ratio grid, so there's 8:1, 12:1. You're going to want to ask what your grid ratio is, because that's going to change what your technique is going to be. And there's actually an equation. It's in this PowerPoint, and I took it out because I don't want you to know the equation yet. Not yet. All right. And they have a focal range that is typically 40 inches or 72 inches. Now, sometimes you can get away with shooting a 40-inch grid at 60 inches and have very little grid cutoff, which is really nice, but don't play with that quite yet. The air gap technique. Okay, so if you don't have a grid, you can actually use an air gap technique. And what we do is we take the OID and we increase the OID, so the object to image distance. So here, we're taking this distance, we're increasing it. So here they have it at 15 centimeters. And the idea is it's equivalent to using a grid. So you shoot the patient cross table, and the image here, you're going to be having a lot of scatter missing the image receptor, because it's going off in different directions. You're going to have some that hits it, but overall it's going to decrease the scatter hitting the image receptor. So if you don't have a grid and your image has a lot of scatter on it, go ahead and use the air gap technique, and it's equivalent to using a grid. But you also have the downfall of magnification, distortion, you lose your detail. You've got all kinds of issues that come with that. But if you need to clean it up real quick, that's the best way to do it. So that is your scatter control. I'll go ahead and post your quiz, so make sure you read the chapter in addition.